Hi guys, good morning. Am I audible to all of you? And can you all see my screen? Right. Okay. So welcome to your first class of anatomy in this session. I am Dr. Debarga Chatterjee. I am a surgeon working in New Delhi. So I'll be taking a few classes on various topics of anatomy. We will be dividing the entire anatomy in various sections, as is the way you learn in your UG classes: upper limb, lower limb, abdomen, thorax, head and neck, and neuroanatomy. And while we are discussing each section, first I will discuss the topics, and at the end of each topic, I will discuss a few MCQs. A few things I would like to mention before we begin. Firstly, uh, the topics, whatever we are discussing here, they are very, very important from your examination point of view, right? In your last exam, almost all the questions that had come from anatomy were covered in these classes, okay? I can't promise you that you will get each and every question from these classes, but for sure you will get most of them from what has been discussed here. And one more request to all of you: if you are short of time, please do read and revise at least whatever topics are being discussed in these classes. You are free to read anything more, anything extra, whatever you want, but do not leave out the topics which are being discussed here, right? Obviously, I can't discuss the entirety of anatomy in these few classes, but I will be discussing the relevant, important questions and the topics, right? And another request: please be interactive. If you have any questions, if you have any doubts, please let me know. At the end, when we are discussing the questions, please participate, please answer. It is okay to be wrong. We are all here to learn. But if you do not answer, if you do not participate, there's no point in having a discussion, right? So, with that in mind, let us start our first class. You are free to take notes. If I am going too fast, please let me know. If you want one more slide to be revised, discussed once again, please let me know, right? So, let's start with the anatomy of upper limb. And the upper limb anatomy, we start with the bones. So, upper limb starts from the shoulder, and then there's the arm, the forearm, the wrist, and the hand. So the main bone of the arm, the only bone of the arm, is the humerus. The forearm consists of two bones, the radius and the ulna. I'm sorry, the spelling is wrong. It is radius, R-A. Then the wrist has the carpal bones, and then the hand, you have the metacarpal bones and the phalanges. So from here, a very important question, which all of you must be knowing, the very important topic is the carpal bones, okay, the wrist. So there are 8 carpal bones arranged in 2 rows from lateral to medial side. You have one proximal row, one distal row. The proximal row starts from scaphoid, lunate, triquetrum, pisiform, scaphoid, lunate, triquetrum, pisiform. Then the trapezium, trapezoid, capitate, and the capitate and the hamate, right? So these 8 bones, all of you know the names, all of you know the very famous mnemonic: she looks too pretty, try to catch her. Very useful mnemonic in the appropriate sequence. We will discuss a bit of scaphoid bone later also, but for now, just remember, from here you must remember few things about scaphoid: that it is the most common carpal bone to get fractured during the fall on an outstretched hand. It is very prone to avascular necrosis because of its blood supply. And Scaphoid fracture, a very classical sign is tenderness in the anatomical snuff box. These 3 points, please remember, I'll tell you once again. Most commonly fractured bone, peculiar blood supply, and tenderness in the anatomical snuff box. These 3 points you must remember for scaphoid bone. And pisiform, this is a sesamoid bone. Sesamoid bone means it is formed in the tendon of a muscle. So the pisiform bone is formed in the tendon of the flexor carpi ulnaris muscle. Okay. So scaphoid and pisiform, these points you must remember. Moving on, the few bones, clavicle. So clavicle is the only long bone which lies horizontally. It is the first bone to ossify in the during the fetal development at the 5th or 6th week of intrauterine life. It is the most commonly fractured bone in the body, and the most common fractured site is the middle 1/3. So if you see the clavicle, so you can divide into 3 parts. Okay, lateral end, medial end, and the middle 1/3. So middle 1/3 is the area which is most prone to fractures. Now, what are the abnormalities that can happen here? Yeah, and one more thing, it is the only long bone with no medullary cavity. It does not form, it has no bone marrow, it does not contribute to formation of blood cells. Okay. So, look at the X-ray. Do you notice anything abnormal in the X-ray? Anyone? Yes, anyone? No?
सर इसमें कोई क्लेविकल नहीं है, क्लेविकल बोन दिख नहीं रही है.
Yes, right. Your name is? Hello? It will be easier if you just write the answers in the chat box. That will be easier. Just write the answers. Right? You can't see clavicles here. Okay. So this is known as a cleidocranial dysostosis. Okay. The person can become very flexible. Moving on, the scapula. The scapula, it extends from the 2nd to 7th ribs on the back. There are various important bony prominences. One is this acromion process. Then you have the spine of scapula. Then you have this coracoid process. So if you start palpating your clavicle from the midline, you have the sternal notch here. You start palpating your clavicle and you go to the lateral most end. The lateral most bony prominence is known as the acromion process. Okay. Below the clavicle, this is the infraclavicular fossa. There, on deep palpation, you may feel a bony prominence, which is known as the coracoid process. Okay, so it is a palpable bony landmark in the infraclavicular fossa. Then you have the glenoid cavity, where the head of the humerus sits to form the shoulder joint, the ball and the socket joint. This is the socket. The ball is the humeral head. And there are 3 borders, the medial border, the lateral border, and the superior border. So the thickest border is the lateral border of the scapula. In this photograph, you see this deformity where the scapula is quite high riding is known as a Sprengel deformity. Okay, high riding scapula. This is often associated with a syndrome known as the Klippel-Feil syndrome. Here you have a triad of a short neck, fused cervical vertebra, and a low hairline. Okay. Sometimes there is abnormal bone in this area, which joins the cervical vertebra to the scapula, which is known as the omovertebral bone. Okay. So, abnormality of scapula, sprangle deformity associated with the Klippel-Feil syndrome with fused cervical vertebra, short neck, low hairline, with or without a abnormal bone, omovertebral bone. Okay. With me so far, all of you? Yes or no? Right. Thank you. Continuing, humerus. So it is the long bone in your arm. The various parts you might remember. I'll just recapitulate here. So at the proximal end, you have the greater tubercle, lesser tubercle, and the intertubercular grooves. These are very important landmarks, which are sites of attachments of important muscles. Coming distally, in the middle, you have this mid shaft. Okay. Okay, sorry. Before that, you have the two necks, the anatomical neck and the surgical neck. Again, clinically, very important points because important nerves and vessels pass around these necks, and fractures of the humerus in these areas can lead to damage of those important structures. We will discuss these very soon. Coming downwards, you have this shaft of humerus with there's a spiral groove here where the radial nerve passes. We'll also read this soon. Then you have the supracondylar region. Supra means above. So these large bony prominences, they are known as condyles. So above the area is a supracondylar region. And on these condyles, you have small bony prominences known as the epicondyles. So you have this lateral epicondyle, medial epicondyle, which are very easily palpable in your elbow. You can feel for yourselves. Again, they are important because they are important bony landmarks and important nerves pass around these structures. Clear? So the two epicondyles are here. Now see, as I was saying, important nerves and vessels pass around the upper end and the shaft of the humerus. What are they? You have the axillary artery and the two branches, the anterior and the posterior circumflex humeral artery. Okay, so you can imagine if there's injury over here, important vessels can get injured. And nerves, you have the axillary nerve, you have the radial nerve, you have the medial nerve, you have the ulnar nerve. So very important vessels and nerves are around various parts of the humerus. Therefore, injuries in various parts of the humerus can result in very specific injuries, which are often asked in your questions, in your examinations. So, in the X-ray, what do you see? Anyone? Look at the X-ray. There's a very prominent condition that you can see in the X-ray.
Fracture in neck of humerus.
Yes, good. Can you be more specific and tell me which neck is fractured here? There are two necks, as we read, surgical and anatomical. Tell me which neck is fractured here.
Surgical neck.
I could not get that. Please type in the chat box. It will be easier for all of us. Right. Surgical neck. So for all clinical purposes, surgical neck of humerus is important, right? So this is, and anatomical neck is more proximal. If you remember this diagram, so anatomical neck is here, surgical neck is little below. So here you see the fracture of the surgical neck of humerus, right? Anatomical neck will be here. So let us see what happens when the various parts get injured. So in the mid region, you have these all the important nerves: median nerve, ulnar nerve, radial nerve, and the brachial artery. So look at this diagram here. So you have fracture at the surgical neck. You have damage to the axillary nerve and the posterior circumflex humeral artery. Okay. You have a mid-shaft fracture. You have injury to the radial nerve and the profunda brachii artery. Supracondylar fracture. Potential damage to the median nerve and the brachial artery. And the medial epicondyle fracture, you have chances of injury to the ulnar nerve and the ulnar collateral artery. Okay, so four nerves, four potential sites of injury: surgical neck, axillary nerve, mid-shaft fracture, radial nerve, supracondylar fracture, median nerve, medial epicondyle fracture, ulnar nerve. Right? Very important topic for your exam. Now, we discuss the, sorry, we discussed the bones and the nerves. Now the muscles of the upper limb. First the arm, then the forearm, then the hand, and we will be discussing the muscles in terms of compartments. So the arm has an anterior and a posterior compartment. What is the advantage of studying it in this way? Because each compartment muscles, the group of muscles have a specific nerve supply and a specific action. So if you remember the muscles in that compartment, you can easily correlate clinically what is the action we're talking about, what is the nerve we're talking about. And reversibly, if you read of any nerve injury and you remember which compartment it supplies, then you can also correlate that, okay, so this nerve is injured, these group of muscles are injured, and you can easily conclude the effect of that nerve injury. We will understand what I am talking about very soon. So let's start with the arm anterior compartment. So look at this diagram. You have three muscles here. So arm anterior compartment, you have the BBC group of muscles: biceps brachii, coracobrachialis, brachialis. So wherever you read the term brachium, brachii, brachium means related to the arm. Latin word brachium means arm related. So biceps brachii, coracobrachialis, brachialis. So all muscles related to the arm. BBC group of muscles supplied by the musculocutaneous nerve. So whenever we will be discussing musculocutaneous nerve, in retrospect, you can understand that if it is damaged, the BBC muscles will be involved. Okay. And their main action is flexion at the elbow. Okay. And supplied by the brachial artery. Then the posterior compartment. Posterior compartment has one big muscle, the triceps brachii. Again, so biceps means two heads by two brachii arms. So biceps, a muscle with two heads in relation to the arm. Triceps brachii, a muscle with three heads in relation to the arm. So three heads. What are the three heads? You can see in the diagram: long head, lateral head, and there's a short head. Okay, so three heads are of triceps. They are innervated by the radial nerve, supplied by the profunda brachii artery. Okay. Now the forearm. Forearm has again an anterior and a posterior compartment. The anterior compartment is divided into two groups of muscles, the superficial and the deep. Okay. So don't get confused with the names, so many names. It's very easy to remember if you understand. So from medial to lateral side. So with respect to the forearm, anything ulnar is on the medial side. Ulnar nerve, ulnaris muscles, they're all on the medial side. Lateral side is the radial side. Radial group of muscles, radial artery, radial, not nerve exactly, but the radial side means lateral side. Okay. So if you go from medial to lateral, the superficial muscles start with the flexor carpi ulnaris, then a very thin muscle, the palmaris longus, then the flexor carpi radialis. Then you have the pronator teres and the flexor digitorum superficialis. Okay. And the deep muscles, there are three muscles: the flexor pollicis longus, flexor digitorum profundus, and the pronator quadratus. So these names, they are derived from Latin words, hence these names, but these names have some meaning. Okay, so flexor carapi ulnaris means the name implies that it's on the ulnar side and it is a flexor muscle. Superficialis means it's a superficial muscle. Profundus means it's a deep muscle. So whenever you read the term profundus, it means it's a deep structure. Okay. Flexor pollicis longus. Pollicis means thumb related. Okay. Pollux is a thumb. So if you understand the names of the muscles, you will know what they do, what they are related to. Okay. So flexor digitorum profundus is a muscle of the flexor group of the digits, and it is a deep muscle. So flexor digitorum profundus. Okay. So 5 superficial muscles, 3 deep muscles, total 8 muscles of the anterior compartment of the forearm. Most of them are innervated by the median nerve. So unless specified, all muscles of the forearm anterior compartment are by the median nerve, except the medial most flexor carpi ulnaris and the medial half of the flexor digitorum profundus, because you have the ulnar nerve on that side. So ulnar nerve supplies the muscles on the ulnar side, that is the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. Everything else by the median nerve. Okay. So main nerve of the anterior compartment flexor group of forearm is the median nerve. Arterial supply of the anterior compartment, ulnar and radial artery. So look at the diagram. So you have these muscles which are of the superficial group. You cannot see the palmaris longus here, but these are the superficial muscles. So this is the medial side, this is the lateral side, and you have these 3 deep muscles. Okay, the profundus, flexor pollicis longus, and the pronator quadratus. Is this okay, all of you? Right. Moving on to the posterior compartment. So posterior compartment again has 2 groups, superficial and deep. These are the extensor group of muscles. Okay, the anterior compartment muscles, they flex the wrist. These muscles, they extend the wrist. They are more bulky as compared to the anterior group. The muscles are the brachioradialis. This is a peculiar muscle because though it is on the extensor compartment, though it is supplied by a nerve of the posterior compartment, its action is flexion. Okay, remember this. Brachioradialis, though a muscle of the extensor compartment, the posterior compartment, it is actually a flexor of the wrist. All the other muscles, they are extensors. Extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, digiti minimi, carpi ulnaris, and gonius. They are all the extensors. Okay. So again, the names you see, this is an extensor muscle on the radial side. Longus and brevis means it is long. Brevis means it is short. Okay. Digiti minimi, in contrast to the anterior group where you had pollicis, pollux, thumb. In this side you have the digiti minimi, which is the little finger. Okay. And the deep muscle, you have the supinator, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and the extensor indicis, index finger, indicis. Okay. So these are the muscles of the posterior compartment. Now, the nerve of the posterior compartment is the posterior interosseous nerve, which is a branch of the radial nerve. Okay. The point to remember is radial nerve per se supplies only 4 muscles. Okay. They are the beat muscles, BEAT. What are they? The brachioradialis, extensor carpi radialis longus, the anconeus, and the triceps. These 4 muscles. Okay. These muscles are the only 4 muscles which are supplied by the radial nerve itself. Okay. All the other muscles of the posterior compartment of the forearm are supplied by its branch, which is the posterior interosseous nerve. Okay. So, posterior interosseous nerve does not supply, the radial nerve does not supply all these muscles. Remember this. Radial nerve supplies these 4 muscles. All the other muscles are supplied by the posterior interosseous nerve. Okay. Of these 4 muscles, triceps is in the arm, no problem. BEA are in the forearm. Clear? So you have all these muscles of the superficial group. These are the superficial, these are the deep muscles. So all of them are supplied by the posterior interosseous nerve except the beat muscles, the brachioradialis, extensor carpi radialis longus, anconeus, and in the arm you have the triceps. Clear? Any questions? Right. So moving on. Coming to the hand. So hand muscles. So hand muscles, the movements of the hand are actually controlled by 2 groups of muscles. One extrinsic muscles, one intrinsic muscles. The extrinsic muscles are not muscles of the hand per se. Okay. So all the muscles we have read so far, the muscles of the forearm, anterior group, posterior group, they control the crude movements of the arm, of the hand. Flexion, extension, grip, all these. So they control the crude movements and a forceful grip. Whereas there are a few intrinsic muscles, not few, several intrinsic muscles which control the fine. There are 5 groups: the thenar group, the hypothenar group, the lumbricals, the interossei, and a few others which do not fall in any of the above 4 categories. So extrinsic muscles we have read. Let us read the intrinsic muscles now. The thenar group. If you see your palm, okay, so there is a short bulge at the base of your thumb, right? So this is the thenar eminence with 3 muscles. What are the 3 muscles? You have the flexor pollicis brevis, you have the abductor pollicis brevis, you have the opponens pollicis. These 3 muscles are responsible for the fine movements of the thumb. Remember these 3 names, okay? They are supplied by the median nerve. Remember this point also. Median nerve supplies the muscles of the thenar eminence, okay? Then the hypothenar group, you see another bulge on this side at the base of the little finger. This is the hypothenar group of muscles, okay? Again, there are 3 short muscles, just corresponding to what we read in the thenar eminence. In the thenar group, we read about the flexor pollicis brevis. We read about the abductor pollicis brevis, and we read about the opponens pollicis, right? We have the corresponding muscles here. We have the opponens digiti minimi, we have the abductor digiti minimi, and we have the flexor digiti minimi, okay? Just the corresponding of the pollux, we have the digiti minimi. Okay, so these 3 muscles form the hypothenar group of muscles. They are supplied by the ulnar nerve. Thenar group, median nerve, hypothenar group, ulnar nerve, right? Then the lumbricals. Lumbricals, there are 4 lumbricals in each hand, each with a finger. The thumb is not counted as a finger per se. Here we have 4 fingers and 1 lumbrical for each finger. Okay. And the action is flexion at the metacarpophalangeal joint and extension at the interphalangeal joint. Okay. Innervation. So this is the lateral side or the radial side. Ignore this radial side. So lateral side is the medial side. Medial side we read it is the ulnar side. Okay. So the medial 2 lumbricals are supplied by the ulnar nerve, the lateral 2 by the medial nerve. Okay. The interossei muscles, they are located between the metacarpal bones. They are of 2 groups, the dorsal and the palmar interossei. They have specific functions. So the dorsal group, they abduct the fingers, abduction. Okay, dab. Dorsal group, they abduct. And the palmar adduct, pad. Palmar adduction, dab and pad. Interossei muscles supplied by the ulnar nerve. And 2 other muscles which do not form in any of the groups. They are palmaris brevis, a small subcutaneous muscle, and adductor pollicis of the thumb. Okay, by the ulnar nerve. So, if you have noticed, we had mentioned that the medial nerve is the main nerve of the forearm, except the flexor carpi ulnaris, the anterior compartment, and the medial half of the flexor digitorum profundus. So main nerve of the forearm anterior compartment is the medial nerve. In the hand, the main nerve is the ulnar nerve. Okay. Excepting 4 muscles, 4 groups of muscles, the Loaf group of muscles. What are they? The lumbricals and the thenar muscles, the opponens pollicis, abductor pollicis brevis, and the flexor pollicis brevis. So remember, the main nerve of the hand is the ulnar nerve, except the Loaf group. The main nerve of the forearm anterior compartment is the medial nerve, except these 2. And the posterior side, it's the pin, the posterior interosseous nerve. Is this clear, all of you, so far with me? Yes or no? Okay, so I assume there are no questions. I'll continue. The brachial plexus. As I mentioned previously, brachial means arm related. Plexus means a network of nerves. So the brachial plexus is simply a network of nerve fibers which supplies the skin and the musculature of the upper limb, right? It starts in the root of the neck, passes through the axilla, and supplies the entire upper extremity. How do the spinal nerves form? So at each vertebral level, paired spinal nerves arise, one on each side. They have a dorsal root and a ventral root. I assume you know. Dorsal means posterior, ventral means anterior. So the 2 roots, they join to form the spinal nerve. Then the nerve gives off 2 branches, the dorsal ramus and the ventral ramus. Okay. Or anterior and posterior ramus. The brachial plexus is formed by the anterior rami of the spinal nerve C5 to T1. This is a very, very, very important point. You must remember. Okay. Anterior rami of the spinal nerve C5 to T1 is from which the brachial plexus arises. This is the anterior, the posterior, they go to the back. How does the brachial plexus continue its course? In the neck, it passes between the two scalene muscles, scalenus anterior, scalenus medius. Okay. Between these two muscles, it passes and then goes to the posterior triangle of the neck. The course of the nerve of the plexus, you must remember, starts from the anterior rami of C5 to T1, then pass between the anterior and the middle scalene muscles, and then go to the posterior triangle of the neck. So you see this diagram here. So C5, C6, C7, C8, T1, the roots of the brachial plexus, they start from here, the roots. Okay. These roots then give three trunks, the superior, the middle, and the inferior trunks of the brachial plexus. Okay. These trunks then divide into divisions. Okay. So each of these trunks, they have a anterior and a posterior division. Anterior and a posterior division. And okay. So 5 roots forming 3 trunks, each trunk dividing into anterior posterior divisions. Now, the anterior division of the superior and the middle trunk, they join to form the lateral cord. The anterior division of the inferior trunk continues as the medial cord. And the posterior of all the 3, they join to form the posterior cord. Is this clear? How the 3 cords are formed? The 2 anterior divisions, they form the lateral cord. The 1 anterior division of the inferior trunk continue as the medial cord, and the 3 posterior divisions, they form the posterior cord. So there are 3 cords: lateral, posterior, and the medial cords. Each of these cords, then they give up the various nerves, as we know. What are they? The lateral cord gives the lateral pectoral nerve, the lateral root of the median nerve, and the musculocutaneous nerve. Okay. The posterior cord, ultra, upper subscapular, lower subscapular, thoracodorsal nerve, radial nerve, axillary nerve. And the medial cord, so there you have the lateral pectoral nerve, so you have the medial pectoral nerve here. You have the lateral root of median nerve, you have the medial root of median nerve here. And you have the medial cutaneous nerve of the arm and the forearm, and the ulnar nerve. Okay. So ulnar nerve, radial nerve, axillary nerve, musculocutaneous nerve. You must remember the root values of these 4 nerves, very important nerves. Okay. Apart from these named nerves, we have few others also which do not form branches of the plexus per se. One of them is very important, the long thoracic nerve, which supplies the serratus anterior, also known as the nerve of Bell, long thoracic nerve of Bell, from the C5, C6, C7 roots. Okay. Then often asked dorsal scapular nerve from the C5 root. Okay. And C5 contributes to the phrenic nerve as well. The root value of phrenic nerve, as you might remember, C3, C4, C5. Okay. So sometimes you may be asked which root of the brachial plexus contributes to the phrenic nerve. This is the C5. Okay. Is this clear to all of you? This is very, very important. Brachial plexus. You will definitely get one question from any of these nerves. Right. So this is how it looks in the cadaver. Okay. You see the 2 roots of median nerve. They form the median nerve. Posteriorly, you have this radial nerve going here. Okay. So they must be in relation to something. Lateral to what? Posterior to what? Medial to what? So the answer to that what is the second part of axillary artery. Okay. So these three cords are named in relation to the second part of the axillary artery. Okay. So axillary artery is here. So behind the artery you can see the this part you can see is the posterior cord. This is the lateral cord. This is the medial cord. Right. So coming to the important named nerves, musculocutaneous nerve, root value C5, C6, C7. You must remember this. Supplies the anterior compartment of the arm, the BBC group of muscles. Okay. And all these nerves, they have a motor component and a sensory component. So muscles, BBC, sensory, it forms the lateral cutaneous branch of the forearm. It is the lateral cutaneous nerve of the forearm. Okay. Axillary nerve, C5, C6 root value. Okay. Its most important supply is the deltoid muscle. Okay. Deltoid muscle maintains the shoulder contour. It is needed for abduction of the arm. Okay. And sensory supply, it supplies this area on the upper lateral aspect of the shoulder where the deltoid is inserted. So you might have seen in the military uniforms, there's a badge in this area. So it's known as a regimental badge area. Very commonly asked. This question was asked in your last examination and it had been discussed in the class. So axillary nerve supplies this regimental badge area. So a very classical finding of axillary nerve injury is loss of shoulder contour. The muscle gets atrophied. So this shoulder bulge is lost. There's weakness of the abduction of the arm, and there is a lack of sensation over the regimental badge area. See, there are so many muscles, so many nerves to supply. Don't remember this one. I'll get back to you. Okay, with this dorsal scapular. What I am discussing right now is what you need to know. Honestly, I don't remember every nerve supply. So if you want to know, I'll get back to you on that. Okay, but thank you for asking. Right, the median nerve. So roots C5 to T1. Median nerve, as I had mentioned, most of the muscles of the anterior compartment of the forearm are supplied by the median nerve. In the hand, you have the thenar group and the lateral lumbricals, the lower group of muscles. Okay, lumbricals, opponens pollicis, abductor pollicis brevis, and the flexor pollicis brevis. Lower muscles in the hand and the anterior compartment in the forearm, except the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. Sensory supply, we will see in the next slide. It is the lateral part of the palm and the lateral 1, 2, 3 and the half fingers with the palmar surface. This is the median nerve distribution. And so I had mentioned the median nerve helps in these muscles, they form the extrinsic muscles of the hand. They help in crude movements, grip. So median nerve is known as the laborer's nerve. The radial nerve supplies the posterior compartment of the arm, the triceps, and its branch supplies all the muscles of the posterior group of the forearm, except the brachioradialis, extensor carpi, that is longus, and the anconeus, which come by the pin, the posterior interosseous nerve, and the sensations, the posterior aspect of the arm and the forearm. Okay, root value C5 to T1. So these two nerves, medial nerve, radial nerve, they have roots from all the five, C5 to T1. And ulnar nerve, C8, T1. Ulnar nerve is the most important nerve of the hand for the fine movements of the hand, except the low of muscles. In the forearm, it has the flexor carpi ulnaris and the medial half of the flexor digitorum profundus, which are not supplied by the medial nerve. Okay, and sensory supplies the medial 1.5 fingers, the palmar and the posterior. So since the ulnar nerve is required for the fine movements of the hand, this is known as the musician's nerve. Is this clear? Yes. Right. So the cutaneous innervation of the hand, if you see a palmar aspect, so the lateral 1, 2, 3.5 supplied by the median nerve. This is the median nerve area. The medial 1.5 by the ulnar nerve. This is the ulnar nerve area. Okay. And on the dorsum, the posterior aspect, this area is by the radial nerve. Now we will briefly discuss the injuries of the various nerves and the subsequent effects. So muscular cutaneous nerve, it is not a very commonly injured nerve. Okay. So if there are stab wounds in the neck, in the upper arm, then this nerve might be injured. So this supplies the muscles, the BBC muscles. So there will be weak elbow flexion and numbness of the lateral forearm because it forms the lateral cutaneous nerve of the forearm. And you might see a wasting of the anterior group. The biceps is the most prominent muscle. Axillary nerve. Very classical finding, very commonly asked. Fracture of the surgical neck of humerus will result in the axillary nerve injury. Sensory loss, axillary nerve supplies the regimental patch area. So surgeon's patch area, whatever the name is. So numbness of this area and deltoid is affected, right? So wasting of deltoid you will find loss of shoulder contour and weak shoulder abduction. Dr. Saroj Sri, I didn't get your question. Can't see the screen. Is my screen visible to all of you? All right. So Dr. Saroj, I think it's something on your side. Shall I continue? Okay. So axillary nerve, fracture of surgical neck, numbness of the regimental patch area, weak shoulder abduction, wasting of deltoid, loss of shoulder contour. Then the radial nerve injury. So the most common scenario of radial nerve injury is shaft of humerus. Shaft of humerus fracture. Mid-shaft fracture results in radial nerve injuries. Okay. Another common finding is pressure of crutches in the armpits. Okay. Falling asleep on the arm. These also lead to radial nerve palsy, the compression. So it's not an injury, not a damage per se, but prolonged compression may lead to some neuropraxia, resulting in temporary transient palsy. So it's also known as crutch palsy or Saturday night palsy. Okay, all of these mean the same thing: radial nerve injury. Crutch paralysis, Saturday night paralysis means radial nerve injury. So radial nerve supply is the posterior aspect of the arm and the forearm. So you will have numbness in the corresponding areas. Motor deficit. So radial nerve supplies the extensor group of muscles of the hand. Ultimately, you will have a wrist drop. If you try to extend the wrist, you can't. So you will have a wrist drop. And the median nerve. So median nerve, you must remember, we had discussed in the starting of our class. Supracondylar fracture of humerus is the most common cause of a median nerve injury. You can have median nerve related problems in carpal tunnel syndrome as well. We will read this. It is a more distal problem. This is a more proximal problem. So we will not discuss the CTS right now. We will focus on the effect of injury in the supracondylar region. So median nerve, numb, thenar eminence, and this area, the median nerve distribution. Median nerve is the nerve of the anterior aspect of the forearm. So you will have weak forearm pronation, wrist flexion. Okay. And if you try to flex the fingers, okay, these three fingers can't be flexed. You will have a hand of benediction on attempted finger flexion. Okay. Then the ulnar nerve injury. Okay. So medial epicondylar fracture. This is the most common cause of a ulnar nerve injury. Sensory loss in the ulnar distribution, the hypothenar area, and the result will be a ulnar claw hand. So if you try to extend your hand, these two cannot be extended. So it's an ulnar claw hand. Okay. Next, the two very famous palsies, very famous topics for questions: Erb's palsy and Klumpke's palsy. How will they differ? So Erb's palsy is basically a upper root injury. C5, C6 injury results in Erb's palsy. And the nerves from these roots are the musculocutaneous nerve, the axillary nerve, the suprascapular nerve, and the nerve to subclavius. As you can see in the color coding, the corresponding muscles get involved. Musculocutaneous nerve, the BBC group; axillary nerve, the deltoid; suprascapular nerve, the supra and infraspinatus; and the subclavius muscles. Involvement of all these muscles cumulatively result in what is known as the waiter's tip hand, the policeman tip hand. So the arm is adducted, medially rotated, extended, pronated, and the wrist is weakly flexed. Okay. This is a classical finding in the Erb's palsy. It's an upper root injury. In contrast, in Klumpke's palsy, what do you have? It's a lower root injury, C81. So ulnar nerve, median nerve, both get involved in Klumpke's palsy. So all the intrinsic hand muscles, they are supplied either by the ulnar nerve or by the median nerve. Maximum by the ulnar nerve, few the lower root by the median nerve. So collectively, all the intrinsic hand muscles get involved in the Klumpke's palsy, resulting in a complete claw hand. Okay. So these diagrams will help you understand. In Erb's palsy, you have the arm adducted, then pronated, medially rotated, and the wrist weakly flexed. In the Klumpke's palsy, you have a complete claw hand. Okay. Is this okay so far? Guys, is it okay? Shall I continue? Previous slide. Sure. Right. Now coming to the arterial supply of the upper limb. So every blood supply in the body starts from the aortic arch. There are three branches from right to left. You have the brachiocephalic trunk, the left common carotid, and the left subclavian. The brachiocephalic trunk gives the right common carotid and the right subclavian. So the two subclavians on each side, they continue to form the axillary artery, brachial artery, which divides to radial and ulnar arteries, and they go to the hand as the digital arteries. Okay. So at what point does the subclavian become the axillary becomes the brachial? There are landmarks. The subclavian becomes the axillary at the lateral border of the first rib. Somewhere over here, at the lateral edge of the first rib, the subclavian is known as the axillary artery. Then the axillary artery is known as the brachial artery at the lower border of the teres major muscle. So, lateral border of the first rib and teres major muscle, they are the landmarks where the artery, the same artery, is changing its names. Okay, subclavian to axillary, axillary to brachial. Subclavian artery has various branches. Simple mnemonic is vitamin C and D. So, vertebral artery, internal thoracic artery, thyrocervical trunk, costocervical trunk, and the dorsal scapular artery. They are divided into three parts. The vitamin is first part, C is second part, D is third part, divided by the scalenus anterior muscle. Okay, so the scalenus anterior muscle divides the subclavian artery into three parts. The pectoralis minor muscle divides the axillary artery into three parts. Okay, so subclavian becomes axillary at the lateral border of the first rib. Then the axillary is again of three parts. Three parts of subclavian, three parts of axillary. Axillary artery, three parts. Branching is very simple. First part, one branch. Second part, two branches. Third part, three branches. So first part, superior thoracic artery. Second part, acromiothoracic, lateral thoracic. Third part, subscapular artery, anterior circumflex humeral artery, and the posterior circumflex humeral artery. Okay. And of these, the largest branch is the subscapular artery. Okay. This is important. Please note down. So look at the diagram. This diagram shows a few very important relations. You see the two scalene muscles, the anterior and the middle scalene muscles. This is the anterior scalene muscle. This is the middle scalene muscle. So anterior to the anterior scalene muscle is this nerve, which is the phrenic nerve. So phrenic nerve lies anterior to the anterior scalene muscle. Then in between the anterior and the middle scalene muscle, as we had read, lies the brachial plexus. Okay, all these nerves you can see between the two scalene muscles. Okay, and again, anterior to the anterior scalene is the subclavian vein. Between the two muscles is the subclavian artery. Okay, so grouping all these together, this is the anterior scalene. This is the middle scalene. Okay, so anterior to anterior scalene, you have this phrenic nerve, you have the subclavian vein. In between, you have the brachial plexus and you have the subclavian artery. Okay, remember this relationship. Questions are often asked. Is this clear? Yes or no? So I assume it is clear. Now the rotator cuff. Very important topic. There are four rotator cuff muscles. Okay, the supraspinatus, infraspinatus, teres minor, and the subscapularis. The supra and infraspinatus muscle supplied by the suprascapular nerve, the teres minor by the axillary nerve, subscapularis by the upper and lower subscapular nerve, and the supra, infra, and teres minor, the S, the I, and the T, they sit on the greater tubercle. Okay. Subscapularis, a very humble muscle. It takes the lesser tubercle. Okay. Subscapularis, it is submissive. It is happy with the lesser tubercle. The other three muscles, SIT, they sit on the greater tubercle. Remember this, very important. Now, around the shoulder, this bone, the humerus, this muscle, the teres minor, this muscle, the teres major, and this muscle, the long head of triceps. These four structures, they form a few spaces which are important clinically because various important structures pass through these spaces, and for you it is important because questions are asked from this area. So you can see the humerus, the teres minor, the teres major, and the triceps, the long head of triceps, they form a quadrangular space. Okay, it's a quadrangular space. The teres minor, teres major, and the long head of triceps form a upper triangular space. Okay, and the humerus, the teres major, and the long head of triceps, they form the lower triangular space. Okay, draw this, very important, very simple. Just draw four lines. You have the humerus over here, you have the teres minor over here, you have the teres major over here, and you have the long head of triceps over here. Okay, so automatically you have one quadrangle and two triangles. This is very important. So you see here, why are they important? The quadrangular space, it contains the axillary nerve and the posterior circumflex humeral vessels. So the same structures which get injured in the fracture of the surgical neck of humerus, they pass. This is the surgical neck of humerus. So fracture in this area will lead to injury of these structures, the axillary nerve and the posterior circumflex humeral vessels. They pass through the quadrangular space. In the upper triangular space, or simply the triangular space, through this passes the circumflex scapular vessels, and the lower triangular space or the triangular interval, same name, don't get confused. It is the space through which the radial nerve and the profunda brachii vessels pass and traverse in the spiral groove of humerus. Okay. So I'll repeat this. Four structures: the humerus, the triceps, and the two teres, minor and major. They form three spaces: triangular space containing the axillary nerve and the posterior circumflex humeral vessels. The upper triangular space or the triangular space contain the circumflex scapular vessels. The triangular interval or the lower triangular space contain the radial nerve and the profunda brachii vessels. This is a very simple way to remember this. So you have the humerus here, you have the teres minor here, teres major here, and the triceps here, and you have the spaces, the quadrangular space, the upper triangular space, and the lower triangular space. Okay? Is this clear to all? I would be happy if you respond. Thank you. On the axilla. So the axilla is actually a pyramid-shaped space, okay, with the apex, four sides, and a base. So the apex is formed by the lateral border of the first rib, as you can see here, the lateral border of the first rib, then the superior border of the scapula, and the posterior border of the clavicle. So these three structures, they form the apex of the pyramid. Then there are four walls. Look at this diagram. The lateral wall is formed by the intertubercular sulcus of the humerus, the medial border by the serratus anterior and the thoracic wall, anterior pectoralis muscles, and posterior subscapularis teres major latissimus dorsi. So these four walls of the axilla and the base formed by the skin and subcutaneous tissue. Right? So what does it contain? It contains the axillary artery, the axillary vein, the axillary lymph nodes, the brachial plexus, and the heads of the muscles, the biceps brachii short head and the coracobrachialis. But these four you must remember: axillary artery, vein, and lymph nodes, very, very important, and the brachial plexus. Okay. Just a minute. Okay. Sorry for the interruption. So that's for axilla. Then the cubital fossa. So this is the space in front of your elbow. It's a triangular area. So if you draw imaginary line between the two epicondyles, the medial and lateral epicondyle, the line that is your base, the medial border by the conator teres, lateral border by the brachioradialis. So it's a triangle, also known as the cubital triangle. What are the contents? So from lateral to medial side, if you come, you have the radial nerve, you have the tendon of the biceps brachii, you have the brachial artery, and you have the medial nerve. So lateral to medial, the contents are tan, the radial nerve before that. Okay, lateral to medial. The skin covering the cubital fossa contains the median cubital vein. So this is present in the roof of the cubital fossa. Remember this, roof of the cubital fossa contains the median cubital vein, which is the most commonly used vein for drawing blood samples. Right? Then the carpal tunnel. So carpal tunnel, this is the space in front of your wrist, on the ventral aspect of your wrist, right here. There's a space known as the carpal tunnel. It contains a few structures, the 9 tendons and the median nerve. This is the most important content of the carpal tunnel. Compression of the median nerve within the carpal tunnel results in carpal tunnel syndrome, which is basically pain and discomfort along the distribution of the median nerve and numbness of the median nerve distribution. And there are various tests which are often performed for examine for the CTS. One is the Tinel sign. So this is the course of the median nerve. So you tap the median nerve in the carpal tunnel, and the patient might have pain in the median nerve distribution, tinel sign, some tingling sensation, and Phalen's maneuver. So if you flex the wrist, this is how it is done. You ask the patient to hold the wrist in flexion for 60 seconds. Okay. If there is numbness, tingling, or pain in the median nerve distribution, it is said Phalen's test is positive. Look at how this structure looks like. So this is a cross section of the wrist. Okay. Seen from the proximal aspect. So this is the base of your thumb, the thinner muscle. This is the base of the little finger, the hypothenar muscle. These are the carpal bones. From the lateral side to medial side, there is a fibrous band, which is known as the flexor retinaculum. Okay. So the space between the carpal bones and the flexor retinaculum is known as the carpal tunnel. It contains these tendons, the tendons of the flexor digitorum superficialis and the profundus, and the flexor pollicis longus, and the median nerve. Okay. No other nerve or vessel or tendon passes in the carpal tunnel. All the other nerves that you know of, tendons that you know of, they all pass above the flexor retinaculum. Okay. So, commonly asked question, which of the following, they will give you 4 or 5 names, which of the following is not a content of the carpal tunnel? Okay. So anything except the median nerve and the tendons of FDS, FDP, and FPL, anything else you find which is not a content. This question was asked in your last examination. Okay. They are asked for the palmaris longus. This was the answer. Okay. So only the median nerve and the tendons of the FDS, FDP, and the flexor pollicis longus, only these structures, they are present in the carpal tunnel. Nothing else, no other artery, no other nerves, no other tendon, no other vein is present in the carpal tunnel. Remember this, very important. Coming to the anatomical snuff box. This is the space in front of your thumb, right here. Okay. This is the lateral side, this is the medial side. So anatomical snuff box is bounded by 3 tendons. On the lateral side, you have the abductor pollicis longus, extensor pollicis brevis, and on the medial side, you have the extensor pollicis longus. Okay. These tendons, they are the boundaries of the anatomical snuff box. Why is it important? It contains the radial artery, branch of the radial nerve, cephalic vein. Clinically, why is it important? As I mentioned at the very beginning of the class, scaphoid fracture. Okay. Scaphoid fracture is a very common fracture, one of the most common fractures during the fall of on an outstretched hand. It is quite hard to diagnose clinically. A very classical clinical feature is pain and tenderness in the anatomical snuff box. So why is scaphoid fracture important? It's a tiny bone in the wrist. How does it matter? It matters because the scaphoid has a retrograde blood supply. The blood vessel enters from the distal end. Okay. So this is the bone. The artery coming from this side doesn't enter from here. It comes and enters retrograde like this. So if there's a fracture over here, the waist of scaphoid, the proximal end may undergo avascular necrosis, resulting in a persistent pain, stiffness, hard to manage, uncomfortable symptoms. Okay. So that is all for our discussion. Obviously, it's not a very exhaustive discussion. You are free to read anything more that you want. But as I said previously, do not skip the topics which I have discussed today. You must read and revise what has been discussed in this class. They are very important topics. They have been asked multiple times. So now we will discuss some questions. Before that, if you want to go back to any screen, if you want me to show you any slide that you might have missed, please tell me. So shall we go with the questions? Yes or no? Workman contracture, I believe, will be dealt in orthopedics. If not, we can always just get back to this. So, no other questions? Let us see what we have here. And I request all of you, please respond. Yes or correct, wrong, doesn't matter. Just participate. Okay. So, winging of scapula. Now, before we start with MCQs, my advice to all of you is before you jump to answer, please read the question very carefully. Okay. Something which may seem very obvious may not be what they're actually asking for. Okay. Do not miss out the question. Read the question very carefully. They may ask you which of the following is so and so except. If you don't, if you miss the word except, you get the entire thing wrong. And in that way, you can miss out very simple questions. So take a moment, read the question, read all the answers, then choose the best answer. Okay. So winging of scapula is due to yes. Anyone else? Anyone has any other answer? Right. So winging of scapula is because of weakness of the serratus anterior muscle, which is supplied by the long thoracic nerve of Bell. So answer is C. Very good. Thank you. Which of the following muscle is a flexor of the elbow joint despite being supplied by an extensor nerve? Take your time. I want all of you to answer. All right. So, first of all, you cannot have two answers. You have a single answer. Now, there are two topics which you have to remember over here. One, what are the elbow flexors? And what are the muscles supplied by the extensor nerve? Okay. So, remember, I had told you brachioradialis was a muscle which was present in the posterior compartment, in the extensor compartment, supplied by the radial nerve, the extensor nerve, but it was actually a flexor in terms of its action. Okay, so brachioradialis is a muscle which is a flexor of the elbow, despite being in the extensor compartment and being supplied by the radial nerve. So answer is brachioradialis. Next question. Largest branch of the axillary artery. So all these questions have been asked in your exam. So please do not forget to revise these questions. They have been taken from your question bank only. So I believe there are about 12 or 13 participants, but only 2 or 3 are answering. Others, please participate. This is for you only. Right. So it's a subscapular artery discussed in the class. Now, read this. Which is the correct statement about the lumbrical muscles of the hand? Right. So, the answer is A. Okay. Now, let me tell you why. Those who have answered B, you read the option carefully. The third and the fourth lumbricals are innervated by the superficial branch of the ulnar nerve. Every word of your question and the options are important. Superficial branch will supply the skin. Okay. Muscles are never supplied by superficial branches. Okay. So this word makes this answer incorrect. Okay. So the first and second lumbricals by the median nerve. This is the right answer. All the tendons arise from the flexor digitorum profundus. Okay. And each is attached to the medial margin of the digital dorsal expansion. So this is again wrong because if you remember the slide where we discussed lumbricals, I had shown you the first and the second lumbricals are unipinnate muscles. Third and fourth, they are bipinnate muscles. Meaning the first and the second lumbricals, they arose like this. This is the tendon of the FDP and they arise like this. Okay. Third and the fourth, they arose from both sides like this. Okay. Let me go back and show you the slide. See, only the first and second lumbricals arise from the lateral side, and these two are from the both the sides. Okay. So this is why you should read every option and read every word very carefully. These simple things makes the answer wrong. Had this word not been there, then this would have been the correct option. So not the superficial branch, but the deep branch, muscular branches. Is this clear to all? Right. Which of the following muscles in the hand is supplied by the median nerve? Take your time. All right. Answer is B. Let us see why. Muscles in the hand, they are all supplied by the ulnar nerve, as you remember, except median nerve had four supplies, the lower of two. They are the lateral to lumbricals. Okay. So the first option says radial or lateral interossei. This negates this answer. All right. Then you have the opponent's pollicis, you have the abductor pollicis brevis, and you have the flexor pollicis brevis. Okay. So this is the right answer. Hmm? Ulnar lumbricals, no. This is the lateral lumbrical or the radial lumbricals. This is in the others group, not in any of these muscles. Okay. So that's why you should read the options very carefully. This one has lumbricals but ulnar. So not ulnar lumbricals. This is radial but not interossei. They have the lumbricals. All right. Understood? So you see, it's a very simple question. But if you don't read the option carefully and don't interpret them properly, you will miss out a very simple question. This is a pretty straightforward question. Is this clear to all? Right. Read this. Others, please. Right. So the answer is, sorry, answer is B. Let us see why. So they're talking about the ulnar nerve injury. Sensory loss over the ulnar 3.5. So ulnar is always 1.5. Okay, there is no 3.5 with ulnar. Excessive sweating is more of a parasympathetic system. Index and middle finger. Index middle finger has nothing to do with ulnar nerve injury. It's always the ulnar claw hand, the medial two digits. Now this one, inability to grip a sheet of paper between his fingers when the hand is placed flat on the table means this requires adduction of the fingers by the interossei, which is the intrinsic muscle supplied by the ulnar nerve. So the answer is B. Tell me. Any more answers? Right. Okay. So let us analyze the question. Global muscle wasting of the left hand. Okay. Means all the intrinsic muscles are involved. Okay. So whenever they're talking about global muscle wasting, means when all the muscles are involved, it means so cumulatively both the ulnar nerve and the median nerve supply all the muscles. No single nerve can supply all the muscles. Okay. So whenever they are talking about a global muscle wasting, it means the innervation of both these muscles have been hampered. Okay. Radial nerve has nothing to do with the left hand, with the hand per se. Okay. So this is ruled out. So now you are stuck between this and this. So ulnar and median nerve both have the T1 nerve root. Okay. So whenever they're talking about global wasting of the hand, it means it's a nerve root injury. Is this clear? Is this clear to you? Okay. Read this. 23-year-old presented with a humeral fracture on the left side, affecting the area of the spiral groove. Very straightforward question. I am disappointed. Spiral groove, radial nerve is the easiest question possible. Axillary nerve is surgical neck of humerus. This is surgical neck. You can't get an easier question than this. I'm very upset with this. Spiral groove, radial nerve injury. Come on, guys. Next, read this. 28-year-old involved in neck stabbing. On surgical exploration, the musculocutaneous nerve has been divided. Which of the following is correct? Tell me. Sorry for that. I'll be done very soon. I just have one more question left. So, the answer is B. So, those who answered A, it is the lateral cord, not the medial cord, right? Supplies skin over the medial aspect of the arm. No, it's the lateral cutaneous nerve. Supplies skin over the shoulder. No. So, it is the now poorly fitting crutch injured the posterior cord of brachial plexus. Which of the following pictures it is likely to produce? So, as I had mentioned, crutch. Crutch palsy is the involvement of the radial nerve. So, whenever you see radial nerve, it is wrist drop. Okay. Winging of scapula because of the long thoracic nerve of Bell. Veterous stiff position, Arves palsy. Upper root palsy, not posterior cord. Sensation of thumb, ring finger, and whole little finger. So this sensation of half of ring and little finger is ulnar nerve. Thinner muscle wasting is median nerve. Okay, this is not fitting a picture. So weak shoulder abduction and wrist drop. This is a feature of radial nerve palsy. This is clear to all. Okay. So thanks guys. That's for today's class. I hope you enjoyed. I hope you understood. Keep practicing MCQs. If you can, please read what has been discussed today. And revision is the key. We will meet soon with our next topic. Right? Thanks.